Thank you all very much for joining us for our virtual community forum here at APT Foundation. I am Lynn Madden. I am the CEO of the APT Foundation, as well as an assistant professor in the Department of Internal Medicine at Yale. We're going to talk today a little bit about a set of issues that I'm very passionate about. And I really appreciate, again, your time this afternoon. Some of you have heard most of this stuff before, but what I've done is I've pulled together some of this data in a slightly different way. What's going to happen is I have a set of slides. I'm going to share them with you for about 25 to 30 minutes, and then we're going to have a good half hour to have a conversation and discussion. I'd really like to hear from people who are here this afternoon. Some of the considerations and issues that we're talking about are complex, and it really does take the whole community to think about these things and to begin doing a different kind of problem solving. So I'm going to start sharing my screen. All right, so the topic of the day is opioid use, overdose deaths, and COVID-19. A global syndemic. I'm going to talk about the open access model and the urgency of treatment. The aim really is thinking about the grim realities of living with COVID here, almost for going on a couple of years. And the statistics about the harm caused by overlapping pandemics. We're going to talk today about a base of evidence for urgently scaling up medications for opioid use disorder even more quickly than we've been able to across the country. In the APT Foundation open access model, some of you are aware that people are enrolled rapidly in medicine for opioid use disorder, irrespective of their ability to pay, and they're provided real-time access to multiple voluntary treatment options. In addition to receiving care for their opioid use, people at APT have access to primary care services, prevention services, and treatment of other chronic illnesses. So the medications that are approved for opioid use disorder by the FDA, the Federal Drug Administration, are Methadone, Buprenorphine, and Naltrexone. So these three medications are used for helping people manage their opioid use disorder. So they're different. They don't all work in the same way, and we're not really going to go into that today. But these medications have some things in common, and they address the symptoms of opioid use disorder, including decreasing or eliminating symptoms of withdrawal from opioids. They reduce the associated risk of contracting hepatitis C, HIV or AIDS, overdose and overdose death. They reduce all-cause mortality or death from all causes, and they reduce illegal activity in the community. Well, we say, well, these sound wonderful. What's the problem? Why don't we have wider access to opioid use disorder? Well, there are many reasons for that. One of them is that there is significant delay in treatment admissions across the United States. The average waiting time for medicine for opioid use disorder is over 30 days. Some of these medications are very expensive. Some people can't afford them. Some people are uninsured. Some people had insurance that doesn't necessarily cover these medications, so that there are significant barriers to access to care when it comes to opioid use disorder. So I like to talk about the prevalence and burden of opioid use disorder. Really, why do we care about this? It's being talked about often these days in terms of a crisis situation or an epidemic, but that's gone a little under the radar with the advent of COVID-19. And despite some of the ongoing harms that we'll talk a bit about together. So between the year 2000 and 2013, the number of people who had a diagnosable opioid use disorder quadrupled. In other words, it went up 4 times in that 13-year time span. Today, in 2019, that's the most recent year that we have data for, 10.1 million people, or nearly 4% of the total population of the United States over 12 and older, have misused an opioid. in the last year. In other words, taken one illicitly, taken more than they were supposed to, taken one that wasn't prescribed to them, that some friend or family member may have given them. Of that 10.1 million people, 1.6 million of them carry the diagnosis of opioid use disorder. So misusing an opioid doesn't give you an opioid use disorder. And there are lots of opioids. So let's just name a few of them. There's heroin, there's fentanyl, there's methadone, there is buprenorphine. All of these things fall in the class of opioids in one way or the other. Opioid use disorder carries with it a very high risk of death. So there's an elevated risk of mortality for people who have opioid use disorder. They have an elevated risk of contracting hepatitis C, viral hepatitis, and an elevated risk of contracting HIV or AIDS. They also have significantly more diagnosable psychosocial problems. The cost to our country alone, and this is a worldwide phenomenon, although the United States consumes about 80% of the world's opioids and has around 5% of the world's population, the cost to the United States exceeds $53 billion a year. And one thing that I think is critical to keep in mind about opioid use disorders is these are chronic relapsing disorders. What that means is people who have a diagnosed opioid use disorder will always have that illness. And sometimes people with chronic illnesses like diabetes or heart disease, they relapse, right? They start doing things that they know isn't in the best interest of their own health. So all substance use disorders are chronic relapsing illnesses. People go in and out of them, gaining hopefully longer time periods of remission or non-drug use over time. And ultimately, the goal is, of course, to get people so that they're no longer using drugs that harm them. So the conceptual framework today that we're going to spend just a few minutes talking about is that access to medication for opioid use disorder is a pressing social justice and public health issue. So these are intertwined public health spheres of concern that are historically and today continue to be managed and funded separately. So you have COVID-19, which is kind of the newest bad situation on the block, if you will, really coming into play in the United States beginning in March of 2020. More than 700,000 people have died from COVID. And many tens of thousands of people are living with long-term COVID symptoms or outcomes from having contracted and being in recovery from COVID. You have substance use disorders that are intertwined with COVID, and we'll talk a little bit about that data, particularly opioid use disorder. You have HIV also intertwined with substance use, and hepatitis C or viral hepatitis intertwined with substance use. So thinking about these 4 issues, there are other things that we could probably add here, but the data, if you will, is very strong when we think about the connection between these particular spheres of public health concern. The complicating effects of substance use disorder when it comes to COVID-19 were visible in increased adverse consequences of COVID-19. So hospitalization and death rates of COVID patients were all elevated in people who had a diagnosed substance use disorder compared to those without. So hospitalizations, 41% versus 30%. And when it comes to death rates, 9 or nearly 10% of those who died had a diagnosed substance use disorder versus 6.6%. Additionally, African Americans with a recent opioid use disorder diagnosis were 4 times more likely to develop COVID-19 compared to whites. So the results show that hypertension, diabetes, cardiovascular disease, and renal diseases, which are risk factors for contracting and having negative consequences of COVID-19, were more prevalent among African Americans than whites with opioid use disorder, right? So this is a picture that we're painting here, that these particular issues of public health concern, and at the moment we're talking about substance use in general and COVID-19 are heavily overlapping. And that's particularly true when it comes to the negative consequences of COVID. And according to the authors, this is from the Center for Disease Control, according to the authors, the study findings underscore the need to screen for and treat substance use disorders as part of the strategy for controlling the pandemic, right? So substance use disorders, it's always been very important to screen and treat for them. Now it's becoming an area that gives us an opportunity to help control the pandemic, right? If we screen and treat people for substance use disorders. So we want to talk just a little bit about overdose death, right? Which is the other real concern that has spiked during the time period of COVID. So this comes again from the CDC, and you can see if we move across the screen, this is January 2015 to July 2020. So COVID had been with us a really solid 3.5 months here by July 2020. And you can see that the slope of this line right here for overdose deaths, this is just the death from overdose, it goes way up beginning in January of 2020. That black line is opioids. Okay, so then you see the blue line is heroin. That's going down a little bit. Heroin is also an opioid, right? And then synthetic opioids, excluding methadone. This is primarily fentanyl. This is that golden colored or brownish line right here. That fentanyl overdose deaths are, and the use of fentanyl is really on the rise in this country. So if we look at the overdose death rate for 2020, that data is pretty cleaned at this point. The final total exceeded 90,000 people who died of overdose in the year 2020. And that year was 3/4 of a pandemic year, if you will. So without dramatic policy and public health interventions, this number is estimated to possibly be in excess of 125,000 people who die by 2020. Right? What I like to say about this, what I don't like to say about it, but a way I try to be very urgent about it is to say, if you take that 90,000 and you divide that by 365 days in a year, that's the equivalent of a big plane crashing every single day, right? That's the equivalent of a large plane crash every single day. This is an urgent and rapidly more concerning set of issues regarding harms of opioid use. Keep in mind that for every fatal overdose, there are 30 non-fatal overdose events. So when you take this number of 90,000 and you multiply it by 30, this holds up pretty well all across the United States with the data that we have. That's hundreds of thousands of people who are experiencing opioid overdose, many of which are non-fatal events and many of which actually cause harm and death. I bring this up because I think that the non-fatal overdose event is actually an opportunity to intervene and perhaps an opportunity to do some screening and help people navigate into treatment. Well, let's move on to substance use and HIV. So substance use disorders, which as we've said are problematic patterns of using alcohol or other substances, are closely associated with HIV and other sexually transmitted illnesses. Injection drug use is a direct route of HIV transmission. If people share needles, syringes, or other injection materials that are contaminated with HIV. There are places in the United States where there is no access to syringe service programs. This also is a major driver of these outbreaks that we see around the country. They are beginning to occur right now in both Kentucky and West Virginia, where syringe service programs are very hard to access. We see outbreaks of HIV. But in addition, it's important to keep in mind that drinking alcohol, ingesting, smoking, or inhaling drugs, they're all associated with increased risk of HIV, right? So there's this big overlap between injection drug use and HIV, but all drug use of any kind increases people's risk-taking behavior. If you already have HIV, substance use can hasten the disease progression. In other words, you get sicker faster, affect the adherence to antiretroviral therapy, which is medication for HIV, and worsen the overall consequences of HIV itself. So we have some evidence-based strategies to really prevent HIV transmission, and I think this is a really interesting set of data here. A lot of this comes from the World Health Organization. So we take opioid agonist therapies, that's buprenorphine and methadone, in whatever form that they're actually given. If you can get the opioid agonist therapy coverage to about 20% of the people in any given location who have an opioid use disorder, you can begin to reduce the transmission of HIV, right? So these are highly interrelated issues. If you can get that coverage to 20%, you start to see a measurable reduction on the acquisition of HIV. What you also see is you see a measurable uptake in the number of people who have HIV who are taking antiretroviral therapies, right? So if you can get them on a medicine for an opioid use disorder and they have HIV, you can help them identify that they have HIV, and they are more likely to go into HIV care and stay in HIV care. So we talk about the opioid agonist therapies or medicines for opioid use disorders as treatment as prevention of HIV, and also treatment as treatment for HIV, right? So there's a lot of reasons from a very intertwined perspective that it makes sense to help people navigate themselves into treatment for their opioid use disorder. When we go to substance use and hepatitis C, about 400,000 people died from hepatitis C in 2016. This is often an asymptomatic illness. In other words, people don't know they have it for a long time. Even though today we have a very good antiretroviral therapies that can cure more than 95% of people who acquire hepatitis C, access to diagnosis and treatment is low across the country and pretty much across the board. Because again, this illness is asymptomatic, people are not aware that they have it, they can spread it, and they can develop the negative consequences of untreated HCV. 23% of these new infections for HCV in a given year are attributable to injection drug use, and 33% of death from HCV is attributable to injection drug use. Although people who do use drugs by injection and people who are incarcerated are not often included in these data. So that data may actually be a bigger number than we're actually aware of. Important to keep in mind, as with HIV, drug use other than injection is also associated with HCV acquisition, right? So drug use of all kinds is associated with risk-taking behaviors, which are associated with the acquisition of this very treatable illness. And treatment with direct-acting antivirals is recommended for everyone. It used to be that there was kind of a set of ideas that people who had hepatitis and who were using drugs or recently recovered in recovery from drug use of any kind were not good candidates for treatment of their HCV. The newer drugs that we have actually minimize that. Almost everybody is a good candidate for treatment for their hepatitis C. Again, this has a public health benefit in that if you know you have HCV, you can learn how not to transmit it. If you know that you have HCV or HIV, you can be treated for these illnesses. So it protects the community as well as the individual person. So what are some of the structural challenges as we really think about, timeliness to treatment and access to treatment for opioid use disorder? Some of the challenges that come up throughout the literature, medicines for opioid use disorder are highly regulated by the federal government. They're often regulated even more so by state governments and or payers. So some examples of this might be mandatory counseling in excess of the federal guidelines. There are several states that have a lot of counseling requirements for patients, special licensing requirements for physicians or other prescribers. There's a lot of structural challenges. It's a complex system when we use medicines for opioid use disorders, and it's not necessarily designed around access to treatment. It's more designed around Making sure that the person receives all of the services that might benefit them down the road, even if those services, those new services such as counseling, are perhaps in the way of programs' ability to scale up. And we can talk more about that if you want to. Medicines such as buprenorphine are are often cost prohibitive. Right? This is a very safe medication. It's often preferred by people over taking methadone, for example, but it's an expensive medication. There are some real challenges around stigma, both among the using population, their family members, but really among our culture as a whole, often even among professional people, that there are a set of ideas that we're substituting one drug for another, or that the medicines don't really work, or maybe you're not really in recovery if you're taking a medicine for your opioid use disorder. And then there's a general lack of clarity regarding proper dosing of these medications. People are often underdosed, and length of time in treatment. I bring this up because if you're underdosed, you're likely to leave treatment and tell other people that you didn't feel very well while you were taking the medicine, right? So you believe that it didn't work for you. On the flip side of that, the person who prescribed you the medicine is having the experience that my patients don't seem to stay in treatment, and they must not be really ready for treatment, right? Or this isn't a very good medication. So there's this kind of loop that goes around when we underdose people on these meds. And then length of time in treatment, a frequent question that I'm often asked is, when can I get off this medicine? Right? How long does a person need to take the medicine? And that's a very interesting question, but they need to take the medicine for as long as it's useful for them. But for most people, that is at least 3 to 5 years, right? At least 3 to 5 years is kind of the floor, if you will, and certainly not the ceiling. And that there are some people who need to take a medicine for opioid use disorder for the rest of their lives, similar to taking a medicine for your diabetes. You might be able to manage your weight and exercise and diet down to a place where you no longer have to take a medicine, but you might not be able to, right? And so you'd have to continue on that medication. There are many other things that need to be looked at. So wait time, the dose of medicine, and rapid treatment entry are associated with taking the medicine to begin with and continuing on the medication. Same-day access to medicines for opioid use disorder is the best case. We know that 72 hours is kind of a magic number. If you reach out for help and can get a diagnosis and a medicine that you're actually taking within 72 hours, you're much more likely to continue than if you are given an appointment somewhere off into the future. So 72 hours is a magic number. Same-day access is best case. Treatment entry is associated with decreased all-cause mortality and reduced death, even if you don't stay on the treatment for a long time. So people learn information as they enter treatment about hepatitis, about HIV, about other health issues, and treatment entry itself is associated with decreased all-cause mortality and reduced death from overdose. And higher or adequate doses are associated with higher retention, a decrease in opioid consumption, and the reduction of addiction severity scores. So in 2007 here at APT, I'm going to run through what really took about 10 years to do quite quickly. We began to systematically identify barriers to treatment. We focused initially on waiting time. There's so many things in this complex world of substance use disorder treatment to focus on, but you can simplify all of that and focus on wait time. We focused on wait time, and we began to think about, why are people waiting and what can we do about that? So we did this using a PDSA, or Plan, Do, Study, Act approach, in which we identified a barrier, we made a plan to change it, then we studied the results, and then we moved forward. So just systematically doing these very small changes 1 or 2 times a month until we got to a place where we are today, which is really same-day admission. Now, I'm not going to go through these slides, but I wanted you to have this available to you. But some of the things we did where we just reordered the events that were happening. So when we started doing this in 2007, we had to give people tests for tuberculosis, right? We had to literally place the test, have it read, and make sure that that was in the record. Well, we were doing that in multiple appointments. First, you came in and you had your psychosocial evaluation. Then you came in to have a physical, and where the PPD test was actually given to you. Then you came back to have the test read, and then you got an appointment to receive your first day of medicine. What we figured out how to do was actually make all of that happen on the same day. Right, so it used to be, for example, to use another example, that patients were admitted only if they had enough money to pay for their treatment on day one, or if they had insurance that paid for their treatment. What we do now is that people are admitted even if they can't pay, and then we help them when they get stabilized on a medicine to figure out how they can, in fact, pay for their treatment, or we give treatment away to some individuals. So this is what happened with wait time being defined as the first face-to-face appointment and the first dose of methadone in the case of this particular slide. So in 2006, after we already met people, so we don't even know how long they waited before they showed up for their admission evaluation appointment. They waited 21 days to get to medication after they had already showed up and been evaluated. We started making some of these changes in 2007, and we were able to get that down to about 8 days, which is really still too long. Remember, 72 hours is kind of that magic window. By 2008, we were getting people in with an average of about 2 days, and today it's about 3 hours. So if you're a good candidate for medication, you have a prescription today for buprenorphine, for methadone, maybe for other mental health care drugs that you might need. You'll receive a physical. All of that happens on the same day. And the average time a new patient spends here with us is about 3 hours before they're invited into the appropriate level of care. And here's what happened to census at the same time. So you can see in 2006, we were right around 1,400 people. Remember, we talked about getting that community coverage rate up to about up to 20% to begin to do things like reduce HIV acquisition. The WHO, World Health Organization, actually recommends getting that rate up to about 40% if you really want to tamp down on those illnesses that are transmitted by injection drug use. So we had 1,400 people using methadone as part of their care in 2006. In 2021, we have 4,435 people. What this doesn't count is approximately 800 people who are using buprenorphine here at App Foundation as part of their treatment, right? So that's another medicine that is FDA approved for the treatment of opioid use disorder. So here's what we learned by looking at our own data. People really will enter treatment in higher numbers when the treatment pathway is smooth. In other words, little or no waiting time. We have to capitalize on that initial motivation. Having people who wait, who have an opioid use disorder or any other substance use disorder, means that most of them, more than half of them, will not show up to their initial evaluation appointment. And partly what we need to keep in mind is they often cannot manage the wait time because of their substance use disorder. So what happens when you have a substance use disorder is you have frontal lobe, the front part of your brain, you have frontal lobe dysfunction. What that means is your organizational skills are poor or impaired. You have little or no motivation. You don't feel much in the way of pleasure at various things. You may be impulsive, prone to anger, right? So people who, if we can capitalize on their motivation, they can come in right now or tomorrow. We can see that they can hang on to their motivation for a day or two, maybe even 3, but hanging on to their motivation for that average wait time in our country of 30 days is really not physiologically or psychologically likely to happen for most people who have substance use disorder. So we waste about half of those intake appointments across the United States. People who enter quickly, i.e. same day or within a day or two, are just as likely to stay in care. So that was the other kind of mythology that we were working against, that somehow people who entered treatment too quickly wouldn't be motivated to stay in treatment, or perhaps weren't motivated to come. What we learned here at the APT Foundation is that, yes, in fact, people who enter treatment do as well in care as people who wait to enter treatment. What we also learned is that there is increased acuity among that patient population at baseline. What that means to us is they come in expressing more symptoms of psychiatric or psychological distress at the front door than their counterparts who waited to come into treatment. So that tells us a couple of different things. So there's an increased acuity at baseline in the area of depression, in the area of relationships, in the area of emotional lability or emotional stress and impulsivity, and also an overall kind of general score. We used the basis 24 to gather this data. Also, interestingly enough, they're more likely to never have been married, which is potentially an indicator of a lack of social support, and they're more likely to identify as a person of color. So in the open access world that we have here at APT Foundation, our patients have, on day one, increased acuity over people who waited to come into treatment, and they're more likely to not have been married, and they're more likely to identify as a person of color. So again, I think there's some social justice implications to really looking at the reduction of wait time. So we were one of the first organizations to really examine an open access model for scaling up medicines for opioid use disorder. And while I continue to stress that primary and secondary prevention strategies are important, they are not the whole answer to managing the needs of large group of individuals with opioid use disorder. That is clearly true as we see opioid use deaths from overdose continuing to climb despite more availability of treatment options around the United States. Scaling up treatment to MOUD is critical to reducing harm, including death associated with opioid use disorder. That's going to take some flexibility from programs and from communities. We have to advocate to ensure that the costs of treatment are covered, although the state of Connecticut does quite well here and has, as many of you may be aware, in the last couple of years in particular, really scaled up its treatment in our settings of incarceration here in Connecticut. The open access model offers one promising public health approach for scaling up opioid use disorder, and there are many opportunities to improve medicines for opioid use disorder for other public health gains, such as testing for hepatitis C, HIV, providing COVID vaccines, providing flu shots, giving people physicals. So we come to the end of my part of this conversation, and really how can you help? I mean, this is a lot of information that we've put out here in the last half hour. You can talk to your friends and neighbors. We really need to continue to decrease stigma regarding identification of opioid use disorder and the medications that we use to treat it. Learn how to recognize the signs and symptoms of overdose. Be prepared to use Naltrexone, which is a medicine for reversing overdose. Encourage community dialogue. APT has speakers available to you to present to various groups. You could attend APT's virtual overdose prevention training, which we have scheduled for October 27th at 2 p.m. The training will be free of charge, and you will end up ultimately with a overdose prevention kit, which includes some doses of Naltrexone that you will be able to administer should you come upon a person who's in an overdose situation. So with that, we'll turn it over to this community that we've created here this afternoon. Looks like we have about 23 people here. And if there are people who would like to comment or ask a question, you can put it in the chat box, or you can unmute if you'd like. I see one question. Oh, sorry. Go ahead, please.
Yes, thanks. I was going to read the question that did come into the chat From Lynn Kelly, I love the language choice. Invited in. Is access to MOUD dependent on participation in other services?
Yeah, that's a really good question. So invited into a level of care or a program, medications for opioid use disorder do come with some requirements for participating in other services. What we've done at the APT Foundation is we've tried to make participation really customer focused. In other words, you can choose what day of the week you come in to receive. There's a minimum standard for methadone of receiving counseling services at least once a month. So you can come in the day and time of your choosing to receive counseling services at the APT Foundation, but you do have to come because we have to meet regulatory guidelines. You can come in 5 times a week if you want to. You can come in 5 times a day if you want to. So we have a menu of services that we publish that are on our website, and they include all kinds of things, sort of traditional recovery kinds of services like 12 steps or thinking about relapse prevention. They also include things like vocational service offerings. They might include services such as journaling or trauma-focused kinds of services, but people can select into the service that they want to attend. And again, they have to attend a minimum of 1 time a month. Most of our patients, if you divide by the patient population, most our average, if you will, of face-to-face counseling time of one kind or another for our patients, and this is just visits that are charted in a particular way as counseling visits, our average is just under 3 hours a month for people. That doesn't count all the time that you might spend with somebody trying to get your transportation needs sorted out or that kind of thing, right? So there's a lot of availability to a service structure for people. The other thing that's required is that there is a federal law that is mirrored by the state of Connecticut, that people who are in treatment using methadone as part of their care have to have a minimum of 8 urine drug screens per year. So they have to have their urine screen, and then we meet with people if they have a positive urine drug screen and talk with them about what's going on. And we might recommend actually that they move to a higher level of care or that they come in more frequently if they're struggling with attendant kind of breakthrough drug use. I think one thing that's really important to keep in mind is that during the pandemic, the federal government and the state of Connecticut changed its guidance around the amount of take-home medication that a person who's on methadone could actually receive. We have had over 4,000 people on enhanced schedules for taking home medicine, and we have had really almost no difficulty among that population. People have done just such an excellent job managing their medications, using services, sometimes even using services by telephone, which was another rule change that came about in the state of Connecticut given the pandemic circumstances. So, you know, I've come to even more firmly believe that given good choices, people who are in treatment for opioid use disorder will make them. They will make choices that are in their own best interest. They really will show up. They really will manage their medications safely. And we really can use the indicators that we have and the resources that we have to keep our eyes on and our attention focused on people who are not doing well. So Deb is asking a question: how many emergency departments will evaluate and assist patients in starting treatment? Yeah, that's a good question. That's a growing movement, Daniel, across the country for emergency departments. And I've actually been personally working in a couple of states to help that process. So the state of Vermont is pretty much doing that universally now. They will start people on buprenorphine in the emergency department if the person is diagnosed with an opioid use disorder and wants to start the medication. They've got a nice system of then feeding those folks out into the community. We do that at Yale New Haven Hospital as well. That's Dr. Gail D'Onofrio, who was really one of the first people with her team to start doing that in the country. But it is not universally adopted across the United States yet. And it represents a real opportunity for the identification of people who have an opioid use disorder, and at least that invitation or offer for them to receive a medication and be connected to a community provider. So a question here, can you talk about the interest that you're seeing from researchers and clinicians in other states, in other countries around the open access model? Sure, we sure can. We persons here who work here at App Foundation, we are working across 5 other states right now in the United States, trying to really advance this set of ideas around open access. We're doing this in a variety of ways. One of the other things that we're doing is we're publishing using App Foundation quality improvement data. I see a couple of my colleagues here, Kathy being one of them, App Foundation data to really publish how well people do, what the considerations are around open access, how these other illnesses are really connected to the, thinking about the identification of an opioid use disorder as a real opportunity to look at people in a more holistic way, right? Can they get well enough to actually seek employment? Can we identify what some of their other illnesses might be so that they can in fact go into care for them, which also reduces the likelihood that they relapse to opioid use. And in addition to that, I've been working with colleagues from Yale University and one of our other program directors here, Scott Farnham, in the country of Ukraine since 2014. The entire country has now adopted an open access model. We have quadrupled the number of people in treatment using medicines for opioid use disorder in that country, where they have the highest growing rate of acquisition of HIV in the world. So that's Eastern Europe and Central Asia. And also more recently working in Kyrgyzstan, Uzbekistan and Tajikistan. So again, that part of the world, Eastern Europe and Central Asia, they have the highest rate of death from HIV, and it's almost all injection drug use and a not very developed set of treatment protocols for the treatment of opioid use disorder because they're former Soviet bloc countries and that was not allowed in the former Soviet Union. So they're getting there. And they're interested. And in fact, I was on the phone with both of those countries this morning, really talking through some of their excellent progress. Ideas about making treatment less stigmatizing. How would we do that? How can we make treatment less stigmatizing? Anyone here in our community today? Kathy, you unmuted.
Get on that soapbox.
Well, at least for a minute or two.
I think that, we're doing a lot of, we're hampered by policy and regulation in so many different ways. And I think getting out some of the messages around historically how methadone treatment is developed is important to a larger community. So we understand that the regulations are based in a cultural context that was meant to scrutinize the people that we treat, and in a way that we do not do with buprenorphine. And I think, one of the things I see is a lot of leveling of, or a lot of promotion of buprenorphine as a medication, giving good and great access to it. But we also know from the research perspective that methadone is, for many people, more reinforcing of a medication. So I think that as researchers and policymakers really need to continue this conversation and look at how do we level the playing field for methadone? How do we make it a less stigmatizing treatment? So the question's beautiful. And I think that the pandemic waivers have given us a platform to, you mentioned giving people choices. They make good, healthy choices for themselves. So some of the research that we're seeing now is highlighting that. And I think that needs to be continued to be pushed.
Mm-hmm. Thanks, Kathy. Other thoughts about reducing stigma?
I think maybe just, talking about it more in a sense that I know before you were talking about it's even stigmatized like within professionals themselves. And I know like with mental health, it's gotten to a better place, less stigmatized. And one of the things now is like you go into a doctor's office and they hand you a paper to screen you for any mental health issues you may be facing. So if they were to start doing that with maybe substance use activities and just going to your regular physical checkup and being asked those questions, kind of makes it seem like it's a more normal issue and it's not as unique.
Thanks, Allie. Another question that just popped up from Lynn Kelly: your commitment to person-centered care, the belief that people can get well as a breath of fresh air. How did open access change your capacity? You spoke to shorten wait time. Did this in turn increase capacity? Well, we could talk for a week about this, but we committed ourselves to reducing wait time. We never, in all capacity in substance use treatment, unless you're talking about a bed, in my personal opinion, is artificial, right? We make up these ratios and we don't actually know if they're the right numbers or not in many cases, right? So if you have a law that says you have to get counseling services once a week, which happens to be on the books in West Virginia for buprenorphine, and the program is limited to a caseload of 50 people per clinician, and the counseling has to be all individual, that's really a challenge. That creates a lot of burdens on the treatment agency. In the case of the APT Foundation, we committed ourselves to reducing wait time. Kathy was actually the opening director there in that program. And we just said, we don't know exactly what's going to happen. So this is where it takes a little bit of sort of stepping out into the unknown. We don't know exactly what's going to happen. We're going to stay here until the people who come in today, we see them all. So we reorganized our treatment program around the data that we actually collected from ourselves, right? So the idea of making appointments is inherently inefficient. No matter what you're getting an appointment for, whether it's getting your teeth cleaned or your oil changed. If you make appointments, there's always somebody who doesn't show up, right? And then that time is wasted. If in fact you just staff yourself little at a time to the actual event, because having an evaluation for a substance use disorder is a billable event. And if you don't waste any time, that 50% is the no-show rate across the United States to evaluation. If you waste half your evaluation time with non-billable events, then it does get really hard to make ends meet. So we didn't add any staff for 2.5 years because we didn't have to, right? People were really busy all day, but they went home at the end of the day and it was over. They had done the whole soup to nuts thing. Then we started to see an increase in the number of people coming through the door, and we had to start adding capacity. We also did entirely drop-in groups, right? So instead of running closed groups, which many organizations do, and which has been historically kind of, a standard, we just ran all open. If you run a closed group for 10 weeks and you start out with 12 people, which is the Medicaid allowable census in a group, by the end of 10 weeks, I guarantee you have 4 or 5 people in the room. It's almost impossible to keep the whole group together for a lot of reasons, right? And if you have 4 or 5 people in the room and you're billing for group therapy, that's a lot different than if you have 12 people in the room and you're billing for group therapy when it comes to actually making ends meet. We took the money that was really created by patients using service, and we turned around and hired more people, right? So we just kept investing in the organization. So we had to make ourselves super efficient, and we did that by delivering services that people actually came to. If you run groups that no one comes to, then that's just a waste of resources, right? So we put everything, we threw the spaghetti against the wall, and whatever stuck in terms of what groups do people love coming to and will come to, those were the groups that we ran more frequently, right? And so it's really all about trying to understand what that customer is interested in, what they'll actually do inside the organization, and then really capitalizing on that. People don't want to wait for services. They don't want to go to groups that they've been to 5 other times, right? I mean, this is what they told us, and they told us because we asked them. So it's just this kind of endless remembering to re-engineer ourselves based on what's actually happening for our patients and based on our own data. So that, Lynn, that's kind of a long answer to your question, but like I said, I clearly could talk about this for a long time. I'm very passionate about this.
Thank you so much. That was fabulous. And I may follow up to hear more of your thoughts later.
I would love that. I would love that. Deb Daniel, you have your hand up.
Oh, I was just, you know what, I forgot I put my hand up. I was just piggybacking off of Allie earlier, and I really like the points that she brought up in regards to stigma. It's very challenging with our healthcare providers, our professional groups that do not understand treatment. We all think that just because somebody is a doctor or a nurse, you know, that they would fully understand addiction treatment, and they don't. They don't learn about it in medical school. They don't learn about it in nursing school. Something really has to be big to change that. What's a really scary point is that right now, if you have an emergency, I think, you know, if this were my child and I had an emergency and say I didn't know about the clinics, or I didn't have connections to all of you to know where to go and get treatment for my child, first place I would think of to go would be to my doctor or to the hospital. Well, they don't provide treatment and they don't know where to tell you to go. When you think about stigma, you know, one of the big things that they're pushing right now in regards to the vaccinations, you know, and supporting people, they're saying, talk to your own provider, somebody who you trust. Okay, so we're getting the message out there, and you know, we're hearing it, and then I look at all of the work that we're doing, and it's still across the country, it's not supported. It's really scary, and I feel for so much of our population out there that don't know what to do or where to go without us helping and directing them. So there's a lot of work that has to be done for sure in regards to the professional population, and the stigma there is huge. So thank you for bringing that up, Allie. That was just a great point. I mean, we could talk about that for a long time, but I don't know how where to even start with that. You know, we start making dents. You know, I know that we're really trying to have, you know, a lot of campaigns through the state. DMIS and DPH have done a fabulous job in getting the message out there, but I think there has to be a more intimate approach as well to the professional folks out there, the prescribers in the community, hospitals, and that sort of thing.
So I totally agree with you. And one of the real, you know, what we took on here at the organization was really a concept of just do it. We're going to do this. We know what we're doing, right? And we're going to keep teaching people who come to the door, because now we have doubled our workforce in the last 10 years, right? We literally have twice as many employees at APT than we did in 2007, and that's all based on census. We have to do exactly what you're suggesting, Deb, over and over again, because we hire people who are trained and licensed, but they haven't had the opportunity to you know, have the kind of training that you're talking about, or really even the experience. You know, it's not the general belief that you can so-called trust the patients who are in treatment for substance use disorder, right? That's not a general idea that people have, or that you can somehow ask them what they want versus telling them what to do. And so we are doing that as an organization. And we've also seriously committed ourselves to medical education. Right, we have a lot of students and interns at every level of professional care going through the APT Foundation, which is an enormous amount of extra work for us here, right? It just is, you got to double do things and that kind of thing. But that's really, you know, another way of thinking about it, trying to get the coalition of the willing, if you will, working on issues of stigma and flat out education and experience. Other questions or comments, anyone, before we go to a different question? We have a few more minutes here. So one question, how unique is it that you have primary care services built into substance use disorder treatment? Is this widely replicable? The answer to that is it varies, right? It is replicable, but it doesn't pay for itself. The way that it gets paid for, if you will, is in a way that's a little more obtuse to understand. One way is that our patients are healthier, therefore they stay in substance abuse treatment longer. They get better over time. So our efficient model of delivering care for substance use disorders pays for the primary care that they need, right? So that it becomes a way of one service line. Again, as I said earlier, these are historically funded very separately from each other, which is probably not a good public policy, right? If we could go back to the drawing board, we might think about braiding these things or intertwining them differently. But I mean, the government really replicates this, right? You have a Department of Public Health, you have the Department of Mental Health and Addiction Services. This is mirrored all across the country. You have money that goes into each of these departments. They have limited resources. They're not necessarily braided together, right? So substance use disorder treatment and primary care can be co-located. Another way of doing that is in a federally qualified health center. App Foundation is not an FQHC, but Cornell Scott Hill Health Center is, for example, here in New Haven, or Fairhaven Community Health. We have some FQHCs. They get enhanced rates for delivering primary care and substance use care. The challenge, I think, under the hood of all of this is the issue of scale up. Right? It's important to treat people at every level, but having 200 people in treatment in a community where you might need 20,000 doesn't really get at the public health issues. It's good for the 200 people, don't get me wrong, and for the people who love them, but it isn't the dramatic kind of scale up response that we actually need to begin seeing some of that data around opioid overdose deaths and the associated harms with opioid use go down. We've got to get those numbers up to 20% or 40%. And that's what organizations that I work with seem to be reluctant to do, right? They seem to be reluctant at some level to just step into this and see where capacity really ends up. You might have noticed on that methadone data slide that the methadone numbers had a little peak here 3 years ago, and they're going down a little bit here at App Foundation. And that's because other methadone programs around the state have opened, or other people have begun prescribing buprenorphine. It's a lot more readily available now than it used to be, right? So that there really is a natural top to that capacity issue, but you have to be willing, I think, to really go there. Other questions, anyone? Oh, here we go. Culture change. How do you manage culture change on the administrative or HR side? Do you have culture change influence through community partnerships? Yeah, that's a really interesting question. You know, at some level, we've tried to manage culture change by being change agents, right? So we do try very hard inside our organization. We've created things that we call APT Philosophy 101, 102. We talk weekly in our staff meetings about, you know, what's it really take to keep open access up, and to keep thinking about newer ways of doing things as opposed to defaulting to more traditional ways of doing things. So we've been managing a lot of that ourselves. I think on the hiring side, we really talk with people at the point of hire about what our philosophy is, even if you don't entirely understand that until you get here and start to experience it. You can actually tell sometimes during the hiring process, if there might be people who are just really uncomfortable with the idea of open access and as little appointment making as possible. And maybe they're just not a good fit for an organization like this, right? So we try to do a lot of support. The other thing that we're doing, as I mentioned, is we're trying to do a lot of publishing in peer-reviewed journals. So we're doing this kind of inner sphere, like what's happening right here at home, here at App Foundation, and then we're doing the larger kind of peer-reviewed stuff. We do have staff like Chris, I can see Chris Evans here. It's on the Chamber of Commerce, working with local employers. through our vocational service program. That's a kind of culture change. The AVS people, APT Vocational Services, have developed good relationships with several important employers in this region. They're changing their minds about just what these people who use treatment services here at APT are like. You know, we have people like Kathy who are serving on local community New Haven level committees or management team meetings. Again, just kind of being part of the community, walking the walk with people, answering the same question over and over again, if that's what you have to do. So culture shift is, I think it takes, there's an arc to it that takes a little long. Martin Luther King said the arc of change is, it bends toward justice, which I believe to be true. But it does take a bit of time and commitment. And I think at the same time, you just have to keep doing it, keep doing the work. You know, there's thousands of people now who are in treatment at the APT Foundation who have had positive experiences in care here, who spread the word. So doing the work like at home as well as in those wider spheres is the answer from my point of view. Right, we've reached the top of the hour. Anyone want the last word? Come on, I know there's some chatty people out here. Well, if not, I thank you all for this hour of your time. It's been really helpful from my point of view, and we'll be in touch.